Good morning and welcome everyone, and thank you for joining us for this very special presentation. This week being Wellness Week, this is the fourth in our week-long series of presentations featuring some of Calgary's leading providers of information, products, and services for 55 plus lifestyle. We hope that these presentations provide you with the ways to enhance your health, stay active, and live your best life. As we gather here today, it's vital we also remember the peoples who have gathered here for millennia. This is the Treaty 7 land of the Indigenous peoples of Southern Alberta, the Blackfoot nations of Siksika, Piikani, Kainai, and the Tsuut'ina First Nation, the Stoney Nakoda nations of Chiniki, Bearspaw, and Wesley, and the historic home of the Northwest Métis and Métis Nation of Alberta Region 3. It is with the goal of reconciliation that we acknowledge the land on which we gather, and we thank the elders of these nations for their timeless contributions to the land. And today we're happy to feature the Libin Cardiovascular Institute with a presentation on diabetes and heart disease. So sweet, it'll break your heart. We're pleased to welcome Dr. David Campbell, who's an assistant professor and clinician scientist at the University of Calgary's Cummings School of Medicine. Dr. Campbell is a specialist in endocrinology and metabolism with a particular focus on type 2 diabetes. He has a PhD in health science research, and his research focuses on equity and access to care. Dr. Campbell, the situations of diabetes seems to be growing and more prevalent all the time. Tell us what we can do to help to prevent or at least manage diabetes and heart disease.
Thank you, Colleen, and thank you for allowing me to be here with you all today. It's my pleasure to be able to speak to you on behalf of the Libin Cardiovascular Institute. I'm just going to try to share my screen here. I'm having some difficulty with it, just getting it into presenter mode. Just give me 1 second. And I'll try and
always
sort that
the
out.
technology.
Yeah, sure is.
I've often said that every one of these is a learning curve.
Yeah, it is. And trying to, two screens and trying to move things from one screen to the other to get it to work properly. But we'll see if I can make it work. Okay, well, I can't figure out how to make that work a little bit a different way here. Okay, so you should be able to see my screen now.
There we go, yes.
Is that okay? Wonderful. So I'm going to be speaking to you today about diabetes, and as I said, representing the Libin Cardiovascular Institute. So before I get into diabetes, just a brief introduction to the Libin Cardiovascular Institute and what we do. So we are a group of researchers as well as clinical care providers in the area of cardiovascular disease and cardiovascular prevention based at the University of Calgary and Alberta Health Services. And we provide cardiovascular care in addition to a number of programs that facilitate cardiovascular research. So these are some of our platforms that facilitate research, and I'm the co-chair of the P2 group, which studies cardiovascular population health and prevention research. And so the Libin Cardiovascular Institute also published this little cartoon a number of years ago, talking about a variety of heartbreakers that we as members of the Libin Cardiovascular Institute are engaged in an epic battle against these various cardiovascular risk factors, which put all of us at risk of suffering heart attacks and strokes and debilitating cardiovascular disease, from greasy foods to cigarette smoking to obesity, psychosocial stress, high blood pressure, and today we'll focus specifically on diabetes because we just passed World Diabetes Day, unbeknownst to many, but November 14th every year is World Diabetes Day. So it worked out quite well that I was asked to speak to you at this time about diabetes because we just passed the Awareness Day for Diabetes, and hopefully the goal of the International Diabetes Federation with World Diabetes Day is that this gives us an opportunity every year to reflect on and to raise awareness about diabetes and the risk factors that come along with diabetes so that everybody might be able to recognize those more readily. And so we'll focus today on Sweetu, which is the name of the Libin's caricature for diabetes. And the description is that she is one sweet villain. She snags her victims with the tempting sweet treats and leaves them with a long-lasting impression of her visit. A little extra around the middle. She often goes after African and Asian Canadians, and she gives her victims kidney problems and heart disease. She may look sweet, but this villain is no joke. So let's talk today about diabetes. So the outline for my talk, I want to talk to you a little bit about diabetes in Canada and the prevalence, as Colleen mentioned, always on the rise. We'll talk about what diabetes is and how it contributes to heart disease as the link to the Libin Cardiovascular Institute. We'll talk about who and what population should be screened for diabetes, and then we'll do an exercise where each of you joining today hopefully will be able to assess your own risk profile and your own risk for diabetes. And at the end, we'll talk a little bit about diabetes prevention and treatment and lowering our risk for diabetes and its complications. So to begin, diabetes in Canada, this slide's already a few years out of date. I think this is from 2017. But at that time, every 3 minutes, another Canadian was diagnosed with diabetes. Most of those are type 2 diabetes. And up to 1/3 of Canadians are currently living with diabetes or pre-diabetes. But many of them don't actually even know that they have it. And so that's the point of World Diabetes Day, and that's the point of me being here to speak with you today, so that we can help you to assess your own risk for diabetes and pre-diabetes. And quite shockingly, 1 in 10 deaths in Canadian adults was directly attributable to diabetes in 2008. And that's 12 years ago now. That number is quite a bit higher. Nobody's repeated that study to see what it is now. But probably 1 in 5 deaths have something to do with diabetes in Canada. And so if you think about how many people actually have diabetes, we're talking probably over 4 million people have diabetes today in Canada. And that number is expected to reach 5 million in the next few years here. And it costs a lot of money. So not only is diabetes debilitating to individuals, but it can also be debilitating to our public healthcare system and to our provincial tax system, because we spend a lot of money caring for people with diabetes. So it's a big problem. And in terms of the cost, I think this describes it really well. So if we even just look at what's happened in the last 15 years, the prevalence of diabetes, or that's how many people have it, has gone from about 4% in 2000 to over 10% now in 2020, with projections up to 12 and even 15% of Canadians having type 2 diabetes. And pre-diabetes is similarly on the rise. And so I don't think this will work because I can't audio share, but that's okay. We'll skip right past that. And maybe I'll just talk briefly about kind of what this video shows. Essentially, it describes the pathophysiology of diabetes, and I might be able to show it. You might not be able to hear the words, but I'll narrate alongside. So hopefully you all can see this from Diabetes UK. So it describes that there are 2 main types of diabetes, type 1 and type 2 diabetes. And type 2 diabetes is by far the most prevalent or common form of type 2 diabetes, but there are a number of other rare forms of diabetes as well. And diabetes happens when there's extra blood sugar or glucose within our bloodstream. And blood glucose gets into our system when we eat foods, and the sugar comes into our intestine and is ultimately absorbed into our blood. And insulin is the hormone that's made by our pancreas, which essentially acts as the key that unlocks the doors that allow the glucose to flow from our bloodstream into the cells of our body, and gives our cells, our brain, and our muscles, and all of our various tissues and organs the energy that it needs from the glucose. And so insulin is really important as that key. But when there's no insulin, or the insulin doesn't work, then the glucose can't get into our cells, and we get a backlog of the glucose in our bloodstream. And type 2 diabetes is when your body still makes insulin, but the insulin can't work properly. It's your body rejects the insulin that you have. And both type 1 and type 2 diabetes result in this increase in sugar levels in our blood, because the sugar can't get to where it needs to go. And ultimately, this leads to a number of symptoms, including having to go to the bathroom frequently, having to be very thirsty, difficulty sleeping, ultimately weight loss, urinary infections, and other symptoms. And over time, it causes damage to heart, eyes, kidneys, and feet as kind of chronic complications of diabetes when our body has no insulin for a prolonged period of time. This shows that there are a number of things that people can do to help mitigate the risk of diabetes complications and treat their diabetes, including physical activity, medications like insulin, having their eyes screened regularly, eating a healthy diet, and a variety of other factors. So with that, we'll move on to the next slide, where we kind of go through some of the potential complications that can result from
Dr. Campbell, I don't want to interrupt, but one of our
people that have
viewers.
diabetes are 25 times more likely to experience vision loss than people.
Sorry, I don't want to interrupt, but one of our viewers has asked if you're able to put your screen show on full screen.
I'm not able to, because when I do that, then I believe it. Oh, are you able to see that? Because it's changing all my screens around. But okay, very good.
Perfect.
Excellent. Okay, good. We know that people with diabetes are 10 to 12 times more likely to be hospitalized for kidney failure and require dialysis. They're more likely to suffer from vision loss and blindness, and have amputations to feet and legs, as well as have heart attacks and strokes. And that's the link to the Libin Cardiovascular Institute. And ultimately, a diagnosis of diabetes results in a loss of lifespan of 5 to 15 years, which is obviously very significant. So many people think diabetes is, not a big deal, and it's very common. And because it is so common, I think we often, it's easy for us to take it for granted and think that it's less serious than it is. But a slide like this serves to kind of remind us that diabetes is a very serious disease. In terms of these complications and how frequent they are, this slide demonstrates rate ratios, or kind of the increased risk of having these complications associated with diabetes. And so we describe these in terms of macrovascular, or those that are related to big blood vessels, and microvascular, or those that are related to very small, tiny blood vessels in your body. And the Public Health Agency of Canada used Canadian data to show that people who have diabetes have a 6 times higher risk of chronic kidney disease, a 12 times higher risk of end-stage kidney disease requiring dialysis, a 20-time increased risk of amputation to the lower limb, and even, these ones look quite small in comparison, but still a 4 times higher risk of heart failure and ischemic heart disease, which is related to heart attacks and strokes. So diabetes is associated with many, many serious complications. And so, how does this happen? And how does diabetes cause heart disease? And so this slide shows nicely that high blood sugar leads to damage to the inside walls of our blood vessels. And the blood needs to flow through these vessels to get to the tissues that and provide the oxygen and the nutrients that our cells need. And over time, the damage on these walls causes a buildup of fatty material called a plaque. And as that progresses, the lumen, or the inside of the blood vessel, gets more and more narrow and reduces the ability of blood to flow to the areas that need it, including our hearts and our brains. And ultimately, when the plaque gets so big and has a little crack in it or a rupture, we get complete blockage of the flow through that blood vessel. And when that happens, it causes the tissue that's on this side to not get the blood that it requires. And when that happens, we suffer a heart attack or a stroke, and that leads to damage and other complications. And so this is how diabetes relates to heart disease, is that it accelerates, or it increases the chance of us developing these plaques and having them grow over time. And so when we look at cardiovascular disease in people with, this is from the International Diabetes Federation, so this is worldwide data. When they look at people in high and middle income countries like Canada, up to 27 per thousand died from cardiovascular disease each year of people with diabetes. 9 per thousand died of stroke each year, and 7 per thousand died from coronary artery disease or heart attacks each year. So really, cardiovascular disease is the leading killer, we know, in Canada, and particularly among people that have underlying diabetes. Now, we also know that people who have MI, as myocardial infarction or heart attack, we know that people who've had previous heart attacks are at higher risk of subsequent heart attacks and strokes. And so that's kind of in the non-diabetic population, people that have a prior heart attack are at about have an 18% chance of having a second heart attack in a 7-year period. And what this slide shows is that ultimately, simply having diabetes is equivalent or greater risk than having had previous heart disease, which is quite striking, because we think that when somebody's had a heart attack, well, they're likely to have a second attack. But people who have diabetes are just as likely to have heart attacks as people who've had previous heart attacks or strokes. So really, really important to understand and take seriously this between diabetes and heart disease. And so one question that people often ask me is that, well, diabetes, when we show numbers like this, some people often say, well, in some ways, diabetes is a worse diagnosis than some other conditions, even some forms of cancer. There's more mortality associated with diabetes than some forms of cancer. And people say, well, maybe that's true, but we have good treatments for diabetes. So why is this still such a problem? Why is it still causing so many heart attacks and strokes and deaths when we have good treatments for it? And ultimately, one of the reasons is because diabetes is one of these silent killers. It's not a condition that people necessarily know they have. It's kind of like high blood pressure or high cholesterol or many of these other cardiovascular risk factors, where if your blood sugar is a little bit high, it may not cause you any symptoms at all. And you can have high blood sugars for years and years and not even know that that's a problem for you. And the whole time that you're ignoring this problem because you don't know it's there, you're developing those plaques and those blockages in your arteries and your blood vessels, and ultimately setting yourself up for heart attack or stroke. And so I want to illustrate this through a case example. And I'm going to tell you about a couple of patients that I've met. I've changed their names and some of the details, but these are patients that I've seen in the past. And so I'm going to tell you about a Joseph and a William. They're about the same age. They're 53 and 56 years old. Joseph was a pilot. He worked for WestJet based here in Calgary. And he was married and had 3 teenage kids, and he considered himself quite a healthy guy. William was 56. He worked in the oil fields. He had moved here from Nova Scotia to work in the oil sector when it was still lucrative to do so. And he was a single guy, but he also considered himself healthy. So even though these two gentlemen both considered themselves healthy, let's consider the kind of trajectory that they went through. So Joseph, because he was a pilot, he had to complete annual physical exams to maintain his license. So he had a family doctor who would see him every year and fill out his paperwork and do all the required screening and testing. And his family doctor at one visit noticed that it had been a year since he'd been screened for diabetes. William, on the other hand, was kind of a typical guy, and many of us guys don't really like to see doctors until we absolutely need to. And so he had, through his 30s and 40s, avoided seeing doctors and didn't have a family doctor. As I said, he worked up north, and he would come and go from Calgary to the oil fields and then back home to Nova Scotia to get a break. And so he was kind of a little bit more transient. He didn't have the same structure that Joseph had to his life. And because of that, William was never screened for diabetes, even though he did have a number of the diabetes risk factors that should have triggered somebody to look. Joseph, on that test, he did screen positive for diabetes early on before developing any symptoms or complications of his diabetes. But William, on the other hand, because he didn't have the opportunity for screening, wasn't diagnosed with diabetes until he was admitted to Foothills Hospital when he came in with a heart attack, even though he'd had diabetes probably for 10 years previous to his heart attack. And so Joseph, when he was diagnosed with diabetes, he was able to reverse his diabetes through lifestyle changes and some medications. He got rid of his diabetes. He no longer has diabetes, and he doesn't need to take any medications. He just needs to keep a close eye on his lifestyle. But William unfortunately suffered heart damage from his heart attack that limits his ability to work. He works a rather physical job, and now he can't be on the oil rigs and working because he gets very short of breath now that his heart is weak. In addition, he needs to take 8 medications a day, including 4 insulin injections every single day. And so I think this kind of paradox illustrates very nicely the importance of screening for diabetes and making a diagnosis early on in the course of the disease, and how much more control and power people have over diabetes if a diagnosis is made earlier, right? I think it's easy for a lot of us to say we'd rather kind of put our heads in the sand and not think too much about whether we've got diabetes or not, because it's stressful and it's worrisome, and so we just go on living our lives. But this story, I think, really illustrates why it's so important that we have opportunities to learn about diabetes and to have ourselves checked for diabetes at appropriate times, and to do these self-assessments that we'll go through in a minute. And so what can be the signs of diabetes? And so these are what the Diabetes Australia has kind of put out as the 4T, the early signs of diabetes. And unfortunately, these aren't all that early. These often happen kind of later in the stage of the disease. So toilet, so having to go to the bathroom frequently, urination in particular, feeling very tired and fatigued all the time, losing a lot of weight unexplained, and being thirsty because you're peeing so much, you have to replace the water that you're peeing out with liquids. And so these can be helpful, But unfortunately, as I said, these often happen later in the course of the disease. And so we want to pick it up earlier than that. And because it is a silent killer and these symptoms happen late, the only way we can make this diagnosis is through screening. And so this is what Diabetes Canada recommends. They say that if you're 40 years or older, you're at risk of diabetes, and you should be tested at least every 3 years. And if you have other risk factors that increase your chance of developing diabetes, you should be tested more frequently and start screening even before the age of 40. So I know that most of us here on the talk today are probably over 55, given the audience. So I would hope that everyone here has been screened for diabetes in the last 3 years. And if not, then it's probably time. But there are some things that make you at higher risk than other things. And so, this is a quick self-assessment. We'll go through a more detailed one in a minute, but ask yourself these questions. Do you have any family member that has diabetes? Are you a member of a high-risk group, meaning African, Arab, Asian, Hispanic, Indigenous, or South Asian descent, or of low socioeconomic status? Do you have complications that are associated with diabetes? Have you ever given birth to a baby that was quite large? Did you have gestational diabetes or diabetes during your pregnancy? Has anybody ever told you you've got pre-diabetes or borderline diabetes or somewhat high blood sugars? And do you have high blood pressure, which often runs hand in hand with high blood sugars? High cholesterol similarly. Are you overweight? And do you have any of these other conditions that are associated with diabetes? So if you have any of those, then you fit into the higher risk category. You should be screened more frequently. But Diabetes Canada goes on to say that actually there's a better way to assess our risk, and that's using something called the CAN risk calculator, where we can actually get a detailed, personalized assessment of our risk for diabetes. And so why don't we go through that now? I would like for everyone here to get a pen and a piece of paper, if you're on the call today, and we're going to go through the CAN risk assessment together, and you're going to assess your own individual personal risk for diabetes. And within the next 5 minutes, you will know your risk for diabetes and what actions you need to take. So this is part of our diabetes awareness efforts for World Diabetes Day. So here's what the CAN risk calculator looks like. And so the first couple of questions are pretty easy. So select your age group. So most people here will either get 13 or 15 points. So break those numbers on your sheet, whether you're 55 to 64 or 65 to 74. And if you're over 74, then you still get 15 points. And then give yourself an extra 6 points if you're male or identify as a man. Okay, and so what we can see here, essentially, the more points you get, the higher risk of diabetes. So we know that the older you get, the more likely you are to develop diabetes. So that's why the points are additive as you get older. And we know that men are at higher risk of diabetes than women. So men get an extra 6 points. Okay. So the next questions are a little bit more tricky and might need some more thought. So be honest, you're not telling me, I don't want anybody to tell me their height and weight, but you need to assess your own height and weight. And they have it here in feet and inches and in centimeters for your ease. So what I want you to do is find your height on the left-hand side. So if you're 6 feet right here, or 182.5 centimeters, then what you're going to do is follow this column along to meet with your weight. And so pick your closest weight. And so if I was 6 foot and 200 pounds, let's say if that was the case, then I would find myself here at 6 foot. I'd follow along until this meets with about 200 pounds, and the number that you get is 28. And that's your body mass index. And so I want you to find your own BMI as on this chart. And what you'll see is that BMIs in the white boxes are those that are considered normal weight or healthy body weight. So BMIs of less than 25 is where we hope people are. Between 25 and 30 are considered overweight in this band here. And then between 30 and 35 is obese. And then this is class 2 obesity, as the body mass index gets higher and higher. So again, be honest with yourself, because that's the only person who's going to see. But find your BMI, and then we go up here and give yourself points according to the body mass index that you identified. So in the example I gave you with 6 foot and 200 pounds, my body mass index would be 28 in the overweight range, and I would give myself 4 points for that body mass index. So everybody's had a chance to do that. We'll give you another minute because I know it takes a little while to kind of figure out exactly what to do and where you fit on this graph. So far we have added points for our gender and our age, and now our height and weight. Okay, everybody's good there? I don't see anybody saying they need more time, so we'll go to the next slide. If you need me to go back, then just say in the chat that you need us to go back to a certain slide. So
I had to do a quick conversion for kilograms to
really
pounds.
important that everybody has a chance to do their own risk assessment here. So let's go to the slide here. What's that, Colleen? Sorry?
I said I had to do a quick conversion. Kilograms
Good.
to
Let's move
pounds.
to the next one. So this, well, yeah, I mean, what's nice is they give it to you in both. Kilograms and pounds are both here on the bottom. So you shouldn't have to use a calculator. So we should be good. Okay, next one is also tricky. And ideally you'd measure your own waist at the level of your belly button. But because we don't have time for everybody to go find a tape measure and measure themselves, I've added a few tricks here on the bottom. So if you're a man, you know what your jeans or your dress pant size is, and just add 2 or 3 inches to that pant size, right? So we wear our pants not right around our waist. So we generally add 2 to 3 inches to your pant size. So if you're a size 32, you add 3 inches, that's a 35, okay? And so if I was a 32, I'm gonna add 35 inches, and that puts me in this bottom category, okay? So if you're a man, that's kind of what you do, and you go up to this section here and use the right size in inches and give yourself the points accordingly. For women, it's a little bit more tricky. And so you can use either your usual size for your bottoms, or if you know your numeric size, and it gives you the estimate in inches here. So go ahead and kind of assess yourself. The sizes vary depending on which clothes you're using, but on average, kind of pick your waist size and plot yourself and give yourself 0 points, 4 points, or 6 points. And note that the ranges are different for men and women. And so we'll let you have a minute there to work through that exercise. Okay, everyone's got that. We'll move on to the next question, number 5. Asks about your level of physical activity. So do you usually do physical activity like brisk walking for at least 30 minutes each day? And that doesn't have to be 30 minutes straight. That can be broken up into, I go for a 15-minute walk in the morning, and then I take the dog out for a walk in the evening for 10 minutes. So at least 30 minutes of cumulative physical activity each day. And that can either be at work or at home. So if you do work in a more physical job and you're walking around all day at work, then that counts too. So give yourself 1 point if you're not physically active. And then how often do you eat fruits and vegetables? So if you're a person who doesn't really like fruits and vegetables, and you don't eat them every day, and you only eat them when your kids give you a hard time about it, then you give yourself a couple of points. But if you're somebody who likes vegetables and you eat them every day, then you get no points for this one. Okay. And the next one is about these related factors that are associated with diabetes. So the first one is about high blood pressure. So have you ever been told that you have high blood pressure, or have you ever taken high blood pressure pills? So even if you're not currently taking them, if you've ever been told that you have high blood pressure or take blood pressure pills, give yourself 4 points. And then, as we mentioned, if you've ever had high blood sugar or diabetes, including during pregnancy, or during an illness, sometimes patients don't normally have diabetes, but then when they come into hospital and they're on certain medications, their blood sugars are high. So if that's the case, then you actually have to give yourself 14 points. And then the third one is, did you ever have a large baby if you're a woman? So if you're a man, you're off the hook for this extra point, but if you're a woman and you had babies, if any one of your babies was more than 9 pounds, give yourself 1 point. Okay. Next is the family history piece. So have any of your blood relatives ever been diagnosed with diabetes? And so this does not include cousins or aunts or uncles. Those don't count, so it gets 0 points. But if you have had children, siblings, or parents with diabetes, you have to give yourself 2 points for each of those categories. And so it does, if you had 2 brothers and a sister that had diabetes, you still only get 2 points. So you can only get up to 8 points here. But mom and dad count separately, siblings count separately, and then children count separately. So you can get up to 8 points depending on how many family members you have that have diabetes. Okay, and then as mentioned on the previous slide, certain ethnicities or racial groups are at higher risk of developing diabetes. And so if you're white or Caucasian, you don't have to give yourself any extra points. But if either of your parents was Indigenous Canadian, you get 3 points. If you're Black or African Canadian, you get 5 points. East Asian race, you get 10 points. South Asian race, you get 11 points. Or other Latin American or Arabic, you get 3 points. And so you can only give yourself one score, pick the highest. So for example, if you're, had a mother who was Indigenous and a father who was Black, then you would give yourself 5 points. So you can only have one of these categories, but up to 11 points. Okay, and then other factors are also related to diabetes. And so level of education here is what's asked. So did you complete high school? Did you go to university? So if you did not complete high school, you get 5 points. If you completed high school but went no further in education, you get 1 point. And if you went to some university or college or completed university, you get 0 points. Okay, I think we're coming close to this is the last question here. So before we move on to the next question, does anybody need to see any of the previous slides? If you just type it into the chat box, then we can go back to that. And I see there's one question on the chat that we'll just come to in a moment.
Dr. Campbell, would following our presentation, would you be able to provide this test in a format that people could print off and work at home if they wish?
Absolutely. Yep, we certainly can. There's a PDF version of this.
Okay.
So some people missed 3 and 4 and 1. So we'll go back to those ones. Okay, so there's 1. 1 is just the age. And so just give yourself a number of points depending on which age category you fit into. Okay. And then 3 and 4 were the other ones. So 3 was the weight and height one. So this is the tricky one. So I'll give you a minute there for the person who needed more time on that one. That was Elizabeth. So again, to reiterate how this one works, you find your height on the left-hand side here, either in inches or in centimeters, and you follow it across until it meets or intersects with your weight on the bottom. And it's in kilograms on the top and pounds on the bottom. So pick whichever category fits you best. And then you find where the intersection point is, and that's the number that you're going to need right there, wherever the intersection is. And that you then bring up here and decide whether you're in the first category, if that number is less than 25, 25 to 29, 30 to 34, or 35 and over. And that tells you the number of points to give yourself here. Okay, so we've done the first question and the third. And I see a couple of questions in the Q&A that we'll come to as well that are really good questions. But first, before we get to the Q&A section, I want to give everybody a chance to find out what their score means. So now that we've answered all 12 questions, add up your score. So add up all the scores that you just wrote down on your page. So you should have 11 or 12 different scores for all of our questions. And the scores will range from 0, or not 0, it's hard to get 0, but all the way up to about 40 or 45 is kind of the highest score you can get. And we essentially break your score down into one of these 3 categories. Score was less than 21, you're considered to be low risk. If your score was 21 to 32, you're moderate risk. And if you're 33 or over, you're considered to be high risk for diabetes. Okay. And so then the recommendations are different for these different groups. If you're low risk, then we go back to the Diabetes Canada recommendation. It says that once you turn 40, you should be screened for diabetes every 3 years. If you're at risk, then you should be screened now, and you should consider undertaking lifestyle modification. And we'll talk about what that means. If you're 33 and over, then you definitely need to be screened for diabetes and as soon as possible. And you should begin undertaking lifestyle modification immediately. So you can kind of see the increased urgency as we move along here. Okay, so before we get into the next piece about, what is this lifestyle modification and what can we do about our risk? So what number you have, whatever category you're in now, I always like to tell people, don't beat yourself up about that. There's nothing you can do about those things. And a lot of these things are actually just inborn, right? If we think about the biggest risk factors are sometimes not modifiable. They're the things related to your ethnicity, they're the things related to your age and your gender, and those aren't things that are really changeable. But there are some things that we can change. So wherever you are today, that's just a starting point. You don't have to be too worried about that, but it does give us a chance to think about how seriously we need to take this. So I will answer those questions. So Val Kendall asked, how is high education related to lower incidence of diabetes? Does one imagine they are a reader, so will educate themselves? So really good question. And so why this one gives extra points is because we know that diabetes incidence, or the chance of developing diabetes, is strongly associated with socioeconomic factors. And that people who are more privileged in life, for whatever reason, born into wealthier households, have a better chance for education, have higher social class, and all of those things protects them against diabetes. And there's a number of possible explanations for this, but one reason in particular relates to chronic stress, and that people who often struggle with issues related to poverty and unstable income, and trying to kind of make ends meet and pay the bills, they're always chronically under this stress, and that releases stress hormones in the body like cortisol and adrenaline, and the chronic exposure to those things actually predispose people to the development of diabetes over time. That's just one explanation. It's a very complex area of research that I'm interested in, and it's still not very well explained or perfectly understood why this association exists, but it's been robust and it's been demonstrated in Canada and in many other societies. So that is why education is associated, and why people with lower education unfortunately get a higher score. And then anonymous attendee asked the question about the ethnic group and why some ethnic groups are at higher risk than others. And that's a really good question as well. And another one, we don't know the full explanation for that, but we do know that people of, it's non-white actually, it's essentially any non-white race, have a higher genetic propensity to develop diabetes. And again, there's many theorized and possible explanations for why this is the case. A lot of them have to do with the idea that, if you think long-term, kind of your ancestors, if you're from one of these other countries and, from Asia or Africa, and if that's where your ancestry is from, then the conservation of energy was really important, right? If you were a hunter-gatherer ancestrally, then there would be an evolutionary advantage to conserving your blood sugar and keeping your blood sugars higher. And so maybe they're less sensitive to insulin than people that live, in the more northern countries in Northern Europe, who didn't face the same types of economic and environmental stimuli and challenges to kind of protecting themselves and their families.
Dr. Campbell.
There's people that think they're epi because people from many of these other countries, and yeah, go ahead.
Sorry, we've got a little delay there. I'm just wondering if maybe you could explain what the difference between diabetes and hypo or hyperglycemic, and are they related?
Yeah, sure, we can talk about that. Absolutely. So diabetes is having, as I showed in that video, is having too much blood sugar in your bloodstream. And so that's called hyperglycemia. So diabetes is essentially a state of hyperglycemia. And hypoglycemia is when the sugar levels in your blood are too low. And generally, except for a few very rare conditions, most people don't have hypoglycemia because your body has a number of mechanisms to raise the blood sugar levels. So you're on insulin treatments and you're giving yourself insulin injections because your body no longer makes its own insulin. And then if you take too much insulin and don't balance that with your food properly, you end up with hypoglycemia or low blood sugar levels. And so very rarely do we see hypoglycemia in patients that do not have diabetes. It is possible, but it's not all that common.
A couple more questions.
Okay. So a couple more questions are popping up. I'm going to leave some of them to the end. So I'm only going to answer the questions that have to do with the risk assessment piece now. So I see Maureen's question here kind of fits in that. So I'll take Maureen's question. Val's will leave to the end. Maureen asks, does the risk of diabetes decrease if one has managed to avoid it and is now older than 74? Really good question, Maureen. What we know is that over time, people's pancreas doesn't work as well. And, I think part of that is because, people would say that our current life expectancy in many ways kind of is longer than it's ever been before. And people would say that, a human pancreas is maybe only meant to last 70 or 80 years. And so we know that no matter what's been your trajectory so far, your risk of diabetes next year is more than it is this year. And that's true for whether you're 35 or 75, that over time, every year that you live, your pancreas has a higher risk of failing than it did in the previous year. So if you've already made it to 74 and you don't have diabetes, good on you. Your pancreas is holding out for you, and that does bode well for you. But that doesn't mean that your risk is lower or going to get less. It's only going to get more and more. So just important that you don't have to do this risk assessment every year, but just realize that and actually you're older than 74. So this risk assessment used data on adults between ages 40 and 74. And so that's why this risk assessment, topped out at 74. And so we couldn't accurately predict your risk category if you're older than 74. But, the same principles apply. So I think it's just important for you, Maureen, and anybody else in the same boat to, if you're in the lower or moderate risk category, to stay in frequent contact with your doctor and get screened for diabetes every couple of years, and ask yourself these questions: am I developing symptoms or signs that would be worrisome for diabetes? So we'll leave Val's question, as I said, to the end, because I think it's a really good question. But any other questions on the risk assessment, we'll take those now. And if not, we'll launch into kind of what do we do about it? Okay, so now you've got your number. Let's ask the question, what can you do to prevent developing diabetes? And so this graphic from the CDC displays a number of things that can be done to help people. But I want to show you some research, and this is a study that was published in the New England Journal of Medicine, one of the leading medical journals, about almost 10 years ago now, from Finland, and it's called the Finnish Diabetes Prevention Program. And what they essentially did is they took 522 middle-aged, overweight subjects, so over that number 25 that we talked about with the BMI, who all had pre-diabetes. So they didn't actually have diabetes yet. They're at a very high risk of developing diabetes. And they gave half of them detailed advice about how to achieve these things. So weight reduction of 5%, decrease your fat intake to less than 30% of all the food energy you consume, reduce your saturated fat, and increase your fiber, increase your exercise, and start eating these healthy foods: whole grains, fruits, vegetables, low-fat milk, low-fat meat. So these are and vegetable oils like olive oil. So this is what they asked people to do. And then they also gave them specific advice on how to do endurance exercise as a way to increase aerobic capacity. So what happened to these people? When they followed them over a 6-year period, the intervention group here on the top are the people who got the advice on how to modify their lifestyle. On the bottom was the group who just kept on living their life as normal. And what we see is that the normal group eventually, what this means is that 100% of them did not have diabetes. By the end of 6 years, only 55% of them did not have diabetes, which means that 45% of that group developed diabetes in 6 years. But if we look at the group who did the exercise and the diet changes, it was only 80% or only 20% that developed diabetes. And so this shows that we can reduce the risk of diabetes developing by 60% by undertaking these rather simple things about losing weight, eating a healthy diet, and exercising. So just with those lifestyle things alone, you can reduce your risk of diabetes by 60%. So back to Diabetes Canada recommends, they say that if you have prediabetes, healthy behavior changes that result in a weight loss of 5% can delay or prevent type 2 diabetes. You can contact a registered dietitian through your family doctor or through the primary care network that you're connected with to help you make those dietary changes. Really important to engage in regular physical activity. And if that's not quite enough to normalize your blood sugar, then your healthcare provider might recommend medication. And as part of that, this is a brand new program that actually is not yet available in Calgary, but will be in the next 3 to 4 months, I understand, that was created by Diabetes Canada along with LMC, which is a group of endocrinologists like me. And they offer this program across the country, which is a 12-month program to help you prevent diabetes. It's based on the findings of the Finnish Diabetes Prevention Program, but tailored to Canadian lifestyle. And it's done mostly virtually. So they connect you with a virtual health coach who will meet with you on the phone or on Zoom like this, and they kind of walk you through and help you make the lifestyle changes that are recommended and provide you with lots of online education. So I provided the website here. If you go to that website today and try to log in, it'll tell you that you live in Calgary, so you're not eligible. And that's just because they're still working out the ethics approvals, because this is being done as part of a research study. And so I'm told by the organizers of the program that they expect this program to be operational and and available to people living in Calgary in the next 3 months or so. So keep your eye on that. Okay, so lifestyle is one thing you can do, but what about the medications? And so a number of studies have looked at medication for prediabetes. And so again, here, what we see is that the placebo, this is people who go on living their life like normal. About 40% of them develop diabetes after 4 years, which is what we saw in that other study as well. The lifestyle group, much lower, again, about a half of the risk of people who get nothing. And if you take medication, this medication called metformin, it's good, it reduces your risk, but not as much as lifestyle. And so this is one of the few cases in medicine where medicine is okay, but we as humans have even a better medicine, and that's changing our lifestyle through weight loss, diet, and physical activity is actually even more powerful than taking medications. So really, really important. And what about newer diet patterns? And I've added this because some people might be aware of there's new talk in the literature about new ways to eat and new dietary patterns. And so the first one is called time-restricted eating. And this is essentially where people limit the amount of time during the day in which they consume calories. And so the average American eating pattern is to eat for about 12 hours a day. Many people, on average, wake up at 7 or 8 in the morning and they eat for 12 hours, right? Between eating their breakfast and their coffee in the morning, and then they eat lunch somewhere in here, and they eat dinner in here, and then a lot of people have a snack 7 or 8 p.m. and then don't eat after that. So your fasting window is only about 10 to 12 hours in the average diet. Well, some researchers recently thought, well, what if we reduce the time in which people eat? We don't actually have to change what they eat or how much they eat, but if you just consume all of your calories in a 6 or an 8 or a 10-hour window and prolong the time in which your body is fasting. And essentially what they've shown is that if you do that, they first did this in mice and rats, and then they even started doing it in human studies. And what they've shown is that if you're able to consume all of your calories in a shorter window, ideally 6 hours, but that's rather hard for people to achieve, but even compressing your eating into 9 or 10 hours a day, then you actually have a number of benefits, including lower blood pressure, lower blood cholesterol, better insulin production, and more insulin sensitivity. So all the things that lead to diabetes developing. So this type of time-restricted eating is actually, only come up in the last 2 or 3 years and shows a lot of promise for helping people prevent diabetes developing. And this study is actually a study that used this, and they followed people's blood sugars over time. And so what you can see is the baseline, which are the triangle people. Their blood sugars kind of waxed and waned through the day. So if we think that these people woke up at 8 o'clock in the morning, they ate their breakfast, and that's why you get a little bit of a spike here. And then it comes down, and they eat their lunch, and it goes up, and then it comes down, and they eat their dinner, and they eat a bedtime snack here around 7 p.m. And then it stays up through most of the night. Well, once they ask people to do this time-restricted feeding, the early schedule, which is kind of a morning schedule, what you see is that people eat their breakfast again. So these are the circles. So they eat their breakfast and the sugars go up. And then they eat their lunch and the sugars go up. And they eat their dinner and the sugars stay up, but then they don't eat anything again. Their last meal is around 5 o'clock p.m. And then the sugars come down, way down, and they stay much, much lower through the night. And that's because their body is going into having what's called the metabolic switch, or they're kind of going into this state of starvation where the body starts using the energy that your body has on its own and doesn't rely on energy from outside sources of food. And ultimately what they're showing here is that this shows a lot of promise in preventing the development of diabetes for people that are at higher risk. So this is new and on the horizon, a possible way forward in preventing diabetes. And lastly here is the low carbohydrate diet, or ketogenic diet. So if you really reduce the number of carbohydrates you eat, so this is diets that are predominantly vegetable based and meat based, but not cutting out all the starches. So no potatoes, no rice, no bread. And people who did that actually were able to lower their blood sugars much more than people who ate a standard or a normal diet. And so this is another new frontier in dieting that has a lot of promise for reducing the incidence of diabetes. So with that, I'm going to skip this next section because I know we're running low on time. And just wanted to, kind of conclude by saying, I hope that you were able to learn some basics about diabetes. I hope that we were able to spend some time discussing the link between diabetes and heart disease. I hope that you now understand who should be screened for diabetes, and most specifically, if you should be screened for diabetes, and to learn a bit about how we can prevent diabetes, no matter where on that risk spectrum you fall. These simple things about a little bit of weight loss, a little bit better diet, and some more physical activity will go a long way to reducing your risk of diabetes and heart disease. And we can work together to eliminate sweet-too from our life. So with that, I'm happy to take any questions. I guess back over to you, Colleen.
That absolutely was very informative, and I really appreciated having that risk calculator. I think a lot of the viewers would concur that it was quite eye-opening. And I think that we've got a few more questions here. I don't know if you'd like to, if you're done with your screen share, if you would like to stop your screen share and then your full screen.
Sure.
And we've got a few more questions here. Val had asked about if ravenous hunger or thirst associated with pre-diabetic or being diabetic.
For sure. And so that is on that 4T list of symptoms that I showed from Diabetes Australia. So thirst and sometimes hunger, but usually thirst, is associated with diabetes. And the reason for that is because if the blood sugar levels are too high in the blood, it makes you pee out all that sugar. Your pee becomes a lot more and you get dehydrated. And so people then get really, really thirsty. So there are lots of things that cause thirst, but one of the things that causes thirst is diabetes. So just because you're thirsty doesn't mean you have diabetes, but it does probably mean you should be checked for diabetes.
Great answer there. And
Jennifer has asked,
go ahead,
if sleep apnea increases the risk. And that's a really good question, Jennifer. Sleep apnea is one of these things that runs along hand in hand with diabetes because they have the same risk factors. So obesity increases your risk of sleep apnea, and obesity also increases your risk of diabetes. I wouldn't say that sleep apnea causes diabetes, but it's just that the same type of people tend to get them. So they are at higher risk. And it's a really good question that it wasn't in the list. And this list, the Canvas calculator was based on kind of population level data, and some of these things weren't available, but definitely sleep apnea is a common co-occurring condition with diabetes. So I would say if you have sleep apnea, I'd bump yourself up one category in wherever your risk prediction landed. So if you are low risk and you have sleep apnea, you consider yourself moderate risk. And if you're moderate risk and you have sleep apnea, then bump yourself up to higher risk and follow the advice appropriately there. Okay, and then does metformin help with weight loss, Molly asks. And metformin does have some evidence to help with weight loss, and not a ton. There are if we're looking for medications that help with weight loss, metformin is one of the weaker ones that contributes. There are much more potent new medications that help with weight loss. And so if weight loss is something you're struggling with, we always say kind of the first go-to is the lifestyle modifications, but that doesn't work for everybody. And some people need medical help. And either your physician or referral to a specialist physician could prescribe one of these more potent medical agents that help with weight loss. So I hope that answers Molly's question. And then Molly also asked, will there be a cost to join the Canadian Diabetes Prevention Program when it becomes available? And the answer is no. So it is actually going to be a free program that is offered to the community. And so it's been available in Ontario for a year and in BC for the last 6 months, and they're not charging for it. So it is a pilot program. So I'd say once it is available, you want to join sooner rather than later because once it fills up, it's full, but it'll be free. And I see there's one question in the chat as well. I see that Vi asked, is pancreatic cancer related to diabetes and pancreas issues? And that's a very good question, and it is. So patients with diabetes are at higher risk of pancreatic cancer. It's still a very rare cancer, both in non-diabetic and in diabetic populations, but it is an increased risk because we know that people with diabetes, pancreas is often struggling and straining and trying to keep up, and that actually does predispose you to cancer risk a little bit. We don't necessarily do anything differently because there isn't really a good way to screen from pancreatic cancer, but that's an emerging area of research as well.
That's something I think has become
I think
quite.
I've answered all the questions, but
That's wonderful. Desania, I think very informative, and it's interesting. I'm hearing more and more about intermittent fasting, or the time-restricted fasting being a healthy way to go for you.